Hey y'all, it has been some time. I am so happy and excited to get back on here with you. And today I've decided to talk about a topic that is probably one of the most challenging conditions that women have to deal with during pregnancy. Yes, you guys. So today we're going to talk about dealing with diabetes during pregnancy, and we're going to mostly focus on gestational diabetes. But we know that about 7% of all pregnancies are affected by diabetes. And out of that 7%, 86% are specifically gestational diabetics. Gestational diabetes is probably one of the most challenging conditions to deal with during pregnancy for a couple of reasons. One, oftentimes for most women, it's a shock, right? Not quite expecting to have that diagnosis or to deal with that condition. And here they are in pregnancy, having to not just change their entire lifestyles at times, not just for themselves, but also for their unborn child that is completely dependent on them making the right decisions. It's also challenging because the monitoring that occurs during pregnancy is often challenging. It requires frequent testing of blood glucose levels at home. It requires monitoring in the office, and it also requires an increase in ultrasounds at times, and sometimes additional appointments with a registered dietitian, additional appointments with a high-risk pregnancy doctor, and additional appointments requiring monitoring towards the end of the pregnancy where we do fetal testing. So it's a lot. It's a lot. And sometimes some of my people in my personal lives who have been diagnosed with diabetes, as well as my patients, really express just the stress and the challenges that they experience, of mostly the mental challenge of having to go through the process of such intense monitoring and surveillance. And then you have all the possibilities that you know may potentially happen. So we know that gestational diabetes not only affect mom, but can also potentially affect the unborn child. For moms, we are concerned about developing conditions such as preeclampsia. So we talked about preeclampsia in another video. And in that video, our midwife in detail described the condition of preeclampsia, which is a very, very concerning condition and very important condition to be familiar with, especially as women of color. But preeclampsia is increased in patients who are diabetic. And similarly, those who have chronic hypertensive disorders are at increased risk for developing diabetes. So the hypertensive disorders and diabetes tend to go, unfortunately, hand in hand. Some of the other things that we're concerned about for women who are diagnosed with diabetes during pregnancy is the fact that we know that there's an increased risk for having a cesarean section birth as opposed to a vaginal birth. We know that C-sections are riskier forms of birth. And then the long term, we're always concerned about what does diabetes mean for the patient that's affected by it in the long run. And we do know that studies have shown that 70% of women who are diagnosed with gestational diabetes during pregnancy, within 22 to 28 years of life later after that index pregnancy, can develop type 2 diabetes. So for some women, this is really concerning because perhaps they have diabetes in their family, or they're just really familiar about what that means and all the potential risks associated with diabetes, that the likelihood, or such a high likelihood, of developing type 2 diabetes in their lifetime is sometimes very scary. And for different ethnic groups, that risk increases. So depending on the race, the ethnicity, and whether or not the woman is affected by obesity, those factors can further increase that likelihood of developing type 2 diabetes if we don't do any intervention, if we're not making lifestyle changes. And for example, our Latinx population, we know that Latin American women are even more likely to develop type 2 diabetes at an earlier onset after the pregnancy. So that number goes up to 60% in just 5 years. 60% in 5 years. And that's why we take it so seriously. And once a woman has completed her pregnancy and given birth, it doesn't end there. We need to continue the care because it's now a long-term risk or a long-term condition. We do retest in the postpartum period to identify those who are truly diabetic or already type 2 diabetics and not just gestational diabetics. But even for those who test negative with their rescreening in the postpartum period, it's so important to continue annual surveillance with a primary care doctor who is aware of your diagnosis during pregnancy and is able to continue some type of surveillance later on throughout your lifetime. So that's really important for women to know. We talked about the impact of gestational diabetes on the mom. Let's talk about the unborn child. So we know that chronic diseases such as hyperlipidemia, high cholesterol levels, we know that hypertension, and we know that diabetes all have some impact on the unborn child. With the unborn child, we are oftentimes concerned about their growth, right? So babies who are born to women who are affected by gestational diabetics are more likely to be larger in size, abnormally larger in size. Just as a side note, for patients who are pre-gestational diabetics, which means they were already affected by diabetes before the pregnancy, they can sometimes encounter abnormal growth of the baby in the opposite direction, where the baby is abnormally small. So we know that diabetes is a condition that affect the vasculature throughout the body, and the placenta is no exception. The placenta is a vascular organ. And so having a condition that affects the health of your blood vessels can potentially affect the health of the placenta. And so that's why pre-gestational diabetics are at risk for having those types of abnormal growth where the baby may be growth restricted. In general, however, for our gestational diabetics, we're more concerned about the abnormally large baby. The other thing that we're concerned about is that babies born to women who have gestational diabetes may be at risk for having hypoglycemia, neonatal hypoglycemia at birth. And that means that their sugar level dropped to a very low, abnormally low level. And we know that hypoglycemia can result in seizures if it's severe enough. The babies can also develop what's called hyperbilirubinemia. So we oftentimes are very familiar with neonatal jaundice, and that's essentially the outcome of hyperbilirubinemia. So these babies are more likely to develop hyperbilirubinemia as an outcome as a result of being in utero in the presence of gestational diabetes. And then we are concerned about the delivery process, right? They're more likely to be affected by birth trauma. They are also more likely to be affected by shoulder dystocias, which is one of the most critical emergencies, obstetrical emergencies that exist. So shoulder dystocia is essentially the head of the baby is delivered and the shoulders are stuck. And that can lead to hypoxia and can actually lead to, if it's an extended amount of time, can in very unfortunate, but also rare cases, lead to death. So one of the other conditions that is most concerning is having a fetal demise or a stillbirth, which we know is increased with the conditions such as gestational diabetes. There's still some gray areas in understanding the role of the control of the sugars or glycemic control in preventing stillbirths, but we do know that they are associated. And so it's a condition that's very serious, and rightfully so. And sometimes as clinicians, we're so focused on really the treatment of the condition and trying to avoid these outcomes that it's so easy to be so focused on the outcomes and sometimes forget that we're dealing with human beings, forget that we're dealing with a mom who has to check her blood sugars multiple times per day. So let's talk about what life is like being a gestational diabetic. So one of the things we try to do is really determine those who are truly gestational diabetics and those who are truly undiagnosed type 2 diabetics, meaning that they're starting out during the pregnancy with diabetes. And that's really important because we know that early onset of diabetes or pregestational diabetes also has an increased risk for malformations. So the presence of high sugar in the blood can lead to malformations, most commonly of the heart, but also of the kidneys, also of the spinal cord. So it's very important to make sure, especially for those who are pregestational diabetics, that their sugars are controlled before even getting pregnant. So for those who are planning to get pregnant, who are already type 2 diabetics or type 1 diabetics, it's really important to make sure that your glycemic control is optimized before getting pregnant to minimize malformations and pregnancy loss. That being said, we try to identify those who may not have been diagnosed. And one of the things that we do is when a mom has certain risk factors, we offer early screening, and we recommend early screening, I should say. So early screening means we use the same diagnostic tools and we apply it ideally at the onset of prenatal care, at the initial visit, because you want to identify as early as possible. So there is really no consensus yet as to what type of screening is the best screening for early screening, but we do know that most commonly we do a 50-gram challenge test, and then we check the blood sugars. Oftentimes we'll do a fasting level first, and then do a blood sugar check 1 hour later. And if that test is super duper high, which sometimes that happens, we do not go on to additional testing. We initiate treatment immediately. If the test is elevated, but not super duper high, not severely elevated, we then go on to do what's called a diagnostic test. So the initial test that is administered is a screening test. So we're identifying women who have some type of of metabolic impairment in how they metabolize and control their sugars. It is not a diagnostic test, it is a screening test. And for the women who we identify who have some type of glucose metabolism impairment, we then go on to do a diagnostic test. And that is a much longer, intense 3-hour test that require adjustments of your diet before undergoing the test. So that being said, what then happens if a woman is positive? If a woman is positive, we assume that likely we are dealing with someone who has some high level of impairment in her glucose metabolism, more likely to be a pregestational diabetic, to be truly a type 2 diabetic that has not been diagnosed before, and now is diagnosed during pregnancy. I will say I have had women who have tested positive in early pregnancy, who are more pre-diabetics, and not truly type 2 diabetics. So it's important also to really confirm the diagnosis of whether or not they're truly type 2 diabetics. Now, certainly if the sugars are hugely high, such as, or someone has a very elevated hemoglobin A1C, then that's pretty confirmatory that we're dealing with pregestational diabetes. In the cases of pregestational diabetes, also, we may do additional assessments to get some assessment of the severity of the disease, whether or not there's already some effect on the retina, whether or not there's already some evidence of kidney injury, making sure that your heart is healthy. And that gives us an idea of the risk level of the pregnancy, because if there's some evidence of end organ injury or damage, then it's a much riskier pregnancy. So who do we offer early testing to? So